Perfect. Well, welcome everybody to our Triad Chapter virtual speaker series. We're really excited to have everyone join us today. So for those of you I've not had the pleasure to meet yet, my name is Bailey Bostelman, and I'm the Director of Chapter Engagement at the Foundation Fighting Blindness. So just a few housekeeping items before we get started. Please be sure to mute your line during the presentation so there'll be little background noise. And we'll also open the floor at the end of the presentation for Q&A so that any questions that may arise during the presentation, you'll have a chance to ask those at the end. During the presentation as well, you can also use the chat function and we'll be able to get through those questions as well. So we have a great speaker with us today who's going to share with us about macular dystrophies. But before we jump into that, I wanted to just give a quick overview about the Foundation Fighting Blindness for those who may not be as familiar with us. So the Foundation Fighting Blindness was organized to drive the research that will provide preventions, treatments, and cures for people affected by retinitis pigmentosa, age-related macular degeneration, Usher syndrome, and the entire spectrum of retinal degenerative diseases. We fund research in the lab, translational research, clinical trials, career development awards, natural history, registry, and we also offer free genetic testing. Today, we're the world's leading private funder of retinal disease research, raising over $856 million to fund sight restoring research. So together, we really are winning. We're on the edge of curing blinding retinal diseases. So that means no more parents being told their children will become blind, no more young adults being told that they will go blind, no more seniors being told their final years will be in the dark. So this is the time for us all to take part in being part of this winning team to be able to help millions of people. We're winning thanks to all of you on this call, as well as all of the community of supporters, volunteers, and donors. Our family of volunteers and leaders stand up for those impacted by blinding diseases. And from day one, they share the latest research advancements and provide access to local resources to guide individuals through their personal journeys. And one way we do that is through our chapter network. So our chapter's visions are to bring the community together to be able to end blinding diseases. And we're doing this by focusing on three main areas: education, resources, and revenue. So we want to share the latest advancements of research with the local community, provide access to local resources to guide individuals through their personal journey, as well as accelerate our mission by participating in our fundraising events and creating new ways to fundraise locally. And so there's plenty of ways to be able to get involved in the foundation if you already are not involved. So you can get involved in our mission by volunteering through your local chapter. We have a fantastic chapter here in the Triad area, and we have a great leadership team. A few ways you can get involved through that is becoming a chapter leader, joining our professional outreach team, or getting involved in local events. You can help us continue to fund sight-saving research by joining the Legacy Society or hosting or participating in a local fundraiser. Our very own Tom Sarin on the call today, as well as our leadership team, they will actually be hosting a disc golf tournament on June 4th at Triad Park in Colonelsville. So we would love to invite all of you to take part of that if you are able. Also, if you're looking to get away and take a little vacation, you can plan a trip to come visit us in Orlando at our National Visions Conference, which is a one-of-a-kind event where individuals who are visually impaired and their families have the opportunity to hear about exciting advancements in blindness research. All of the attendees will be able to gain practical skills for coping with vision loss, learn about products and services that can improve their lives, and connect with others across the country. So lastly, I do want to also share with you about my Retina Tracker if you are not familiar with it. So it is a research database of people and families affected by rare inherited retinal degenerative diseases. And its goal is to help us accelerate the mission and drive discoveries for treatments and cures. So by using the data in my Retina Tracker registry, it helps us really be able to understand how common each disease type is and how it impacts people's lives and how it progresses. And then it also helps us learn more about the genes that cause the disease and helps researchers and companies to effectively find people who might be interested in participating in research studies and clinical trials. So if you haven't already signed up for that, I would recommend you do so as well. And now I would like to hand it over to our special guest today, Dr. Yanacone, who is the professor of ophthalmology at Duke and the director at the Central of Retinal Degeneration and Ophthalmic Genetic Diseases. So Dr. I, thank you for joining us this evening, and you can take us from here.
Thank you, Bailey, for your lovely introduction and the premises about the foundation. I would like to echo what you said. I can speak directly from experience of the important role the Foundation Fighting Blindness has been, having for all of our IRDs, inherited retinal diseases, and been a direct and indirect beneficiary of that as well. We're conducting a number of the studies that the Foundation Fighting Blindness developed and sponsored. And at the same time, we are also beneficiaries of the educational support for my current fellow, who's training to become a full-fledged IRD specialist with us and received a clinical research fellowship award from the Foundation Fighting Blindness. And he's going to be staying as a faculty member with us come July 1st. So these are all things that are, are playing a fundamental role in the advancements for IRDs, and it's critically important. So everybody's support, through FFB is really instrumental from this point of view. We're very grateful for all of that. The focus of today's update is, as it shows, is macular dystrophies. And we can advance to the next slide, Bailey, if you wouldn't mind. That's just a quick flash. Simply to acknowledge my disclosures, I receive research funding from a number of companies and other entities, including Foundation Fighting Blindness. I consult for a number of them as well. I serve as well on scientific advisory boards, and I have my own small consulting activity to this extent, as well as I receive very small, I have to say, but nonetheless royalties for this book that we wrote a couple of years back. The next slide. We'll start from, I guess, making sure that everybody understands what we talk about when we're referring to a macular dystrophy. And first of all, what is the macula? I hope that it's clear to everyone, but the macula is the very center of the retina, or the picture that is shown up at the top and to the left in color, that shows the actual real color appearance of the back of a normal eye. And what I hope everyone can see is that there is a structure out of which you see some red structures that are kind of fanning out of that. And that is the optic nerve with the blood vessels that we have that bring all the nourishment to the retina. And tucked in the middle of it, there's a darker spot, which is a darker yellow appearance, and that's what is the macula. It's right in the center, in that C-shaped space off to the left of the nerve. It's just the conventional way of looking at the back of the eye, and that's the area over there that gets affected by macular dystrophies and any other macular disease, including macular degeneration. Onto the right, there is the image of that same eye showing something different. It's still the same area that is being imaged, but this is a test that's called fundus autofluorescent, FAF for short. What it's showing is not the real color appearance of the back of the eye, but the spontaneous glow that comes from the back of the eye, not from the retina, but actually from the layer that is underneath the retina, which we call the retinal pigment epithelium, or RPE for short. In a section of that, the retina and the RPE is shown in the bottom panel, which we can image these days through this test, which I'm sure everybody has heard of or have had one, just called the OCT, Optical Coherence Tomography. It's a high-resolution ultrasound scan of the back of the eye that shows all the fine details of what the retina looks like. You ought to understand that the retina is thinner than a sheet of paper, but in reality, when you look at it magnified, that's what it looks like, and there's a whole bunch of layers within it. The retina is the area there where the yellow bracket in writing is pointing at. At the very bottom, there is a white layer right underneath it, which is the RPE, which is what is imaged in the fundus autofluorescence. So one way that for people that are confused sometimes by the soul relationship, I like to make an analogy, and as we heard at the beginning, most people that know me know that I like to cook and I'm a foodie. So it's easy for me to make analogies that relate to food. So in this particular case, I would have to say that the retina is to the RPE the same that a hamburger is to a slice of cheddar cheese right on top of it. And so the RPE is the cheese layer and the retina is the hamburger layer. So they're two different things, but they're physically glued to one another. And in the specific case of the macula, but that's true of the whole retina, we need a healthy cheese layer underneath it for the hamburger to stay healthy as well. And as we'll see in a couple of examples, unfortunately, that's what part of the problem when disease of the macula starts happening, that there is a failure, one affects the other and then creates a vicious cycle. And turns that nice even cheddar the way it should be as it shows up in the color picture instead into Swiss cheese, and that starts creating trouble for the overlying retina. So Bailey, if you don't want to mind just moving on to the next slide. So when we use the term macular dystrophy, it's really a big umbrella term. There's many types of macular dystrophies. There's many inheritance patterns of macular dystrophies as well, which are summarized there, which are recessive, dominant, X-linked, and even mitochondrial. And I'll explain that in a minute, because that's very important. Something that the patients don't always think of or even are aware of, but it makes a huge difference for the family-wide counseling and all the reproductive risk that patients affected with these conditions may have, and so on. Now, I'd like to touch later on what does a macular dystrophy do to our vision? How do we diagnose a macular dystrophy? What treatment options we have, and how can we overcome the visual burden imposed by macular dystrophy even today? So let's move on to, actually, maybe before we do that, bear with me, Bailey. I promised that I would tell you a little bit about the inheritance patterns. So for those who are not familiar with it, recessive means that there's usually no family history within the family. And so it's always a surprise when a recessive disease comes to surface because nobody was aware of there being any family history of the condition. But it just so happens in those cases that the parents were unaware carriers, each of a predisposition to that same condition caused by that same gene. And so long as they have two disease-causing changes in the gene that causes that particular condition, then they unknowingly have a 25% chance, so 1 in 4, of having an affected child. And they don't discover that until a child with that condition is actually born. The dominant condition instead typically has a known history within the family, although the history of dominant disorders sometimes can be a little tricky to assess because there can be types of dominant disorders that skip generations and can have a number of people who are actually affected, but they're even unaware of having that problem. And in that case, the condition is transmitted vertically from generation to generation. And whoever is affected, whether they're aware of being affected or not, so long as they have the gene change, they have a 50% chance of having a child that is affected with that same condition. So twice as high as in the recessive. Then there is the X-linked kind of possibility. X-linked is a little different because there is a family history here, typically, but by rule, it tends to skip generations. And so you will have only males that are typically fully affected in X-linked disorders. And their mothers are typically the carriers. And so in these particular cases, if there is a family history, it may be that there is a maternal uncle who has the condition, or maybe the father of the mother of our patient had the history of that, but no direct person affected among the parents of the patient. And last but by no means least, in fact, it's something that we see quite a bit. I saw a case of that today. It's the mitochondrial inheritance. This is the trickiest to figure out, but it follows a very different pattern of inheritance. It's similar to X-linked because it still follows the maternal lineage, but it can only be passed on by females. So an affected male cannot pass it on to anybody, but only a female can pass it on. And that's just because of the mitochondrial DNA is inherited in a different way than the regular genes. And what's key about it is that typically mitochondrial macular dystrophies are frankly more treatable than the other types. So it's very important to document whether that's at play, but it also they also typically come along with other findings, which can include hearing loss, diabetes, muscle pains, fatigue, and other symptoms like that, which more often than not go undetected, or patients simply don't think about sharing with their eye doctor because they don't think it's relevant. So these are very important things. I'll show you quickly some examples in the next slide, Bailey. So here are some examples of the various types, the most common types. Frankly, certainly this is not an exhaustive array of images, but I hope that you can appreciate that in every case, there is some change in these images right in the middle of that area that I alluded to earlier that I called you, I defined for you, the macula. So on the top line of images, the first 4 images are 4 different facets of Stargardt's disease. The first, the third, and the fourth are the recessive type, the ones that are linked to the ABCA4 gene, which you probably have heard of, and that has a lot of implications. We'll talk about that once we talk about the diagnostics and the treatments and the approaches. The second image over there that seems somewhat indistinguishable from some of the others is actually the dominant form of Stargardt-like disease, which is instead caused by a completely different gene, which is called ELOBL4. And last on the top line over there, very similar to the second, is another case. In fact, for those who have been associated with Foundation Fighting Blindness long enough, you all may remember Steve Rose, who was our director of research basically for Foundation Fighting Blindness. And that's a patient that he sent to me. That patient had been told he had Stargardt's. Well, turns out that he didn't. And in fact, it was a dominant disorder in this particular case, not recessive. And thanks to the discovery, we were able to handle him a little bit better. But more importantly, we were also able to achieve early detection of affection in one of his own children, which otherwise would have been not something we would normally pursue in Stargardt's. The middle series of images, starting from the left, show instead another very common dominant disorder, which is Best disease, which is what we call vitelliform macular dystrophy, that causes lesions that instead accumulate yellowish material in the very center of the macula, sometimes they can have satellite lesions, like in the example shown there. And the typical inheritance of this condition is dominant, but more recently, and that's what the next 2 images over show, it's been discovered, and now it's been about 12, 13 years or so that it's been discovered, there is also a recessive version of this. And that's obviously a big distinction again, because one thing is to deal with the dominant disease, one other thing is to deal with a recessive one, especially when it comes to counseling patients about the risk of having affected children. And treatments, fortunately, are being developed for these conditions too. Recessive, by paradox, even though it's the more rare, may actually be the one to which we get to more quickly from a treatment standpoint. Next over, the last two images are the instead images from a patient that has a different kind of macular dystrophy, which is called pattern dystrophy. Pattern dystrophies tend to have like wings off to the side and little spoke wheel patterns of bright deposits or yellowish deposits at the back of the eye. Again, she had been told initially that she probably had Stargardt's, but it turns out it wasn't. It was a different kind of macular dystrophy, which is also a macular dystrophy, which we knew once we discovered the gene is uniquely prone to certain kind of complications are typically seen only in macular degeneration of the age-related type. So they can have exudative complications, and those exudative complications can actually be treated in these patients just as successfully with the same treatments that we use for age-related macular degeneration as in these ones. And that this one particular patient, in fact, was one of those patients that did develop it in her 40s. And thank God I had alerted her to that. And so she alerted us right away when a complication developed. We were able to treat her successfully. And despite having a macular dystrophy, she's still retaining 20/20. Down at the bottom to the left, you can see more of that cheese, Swiss cheese kind of effect that I was alluding to earlier. And that's where those yellow spots that you see in the macular region happen for the patient. That too had been suspected of having Stargardt's, but after doing in this case, a dye test, which is called the fluorescein angiogram, we started to notice that there were those darker streaks across the back of the eye in between the areas where the holes in the cheese layer had developed. To cut a long story short, this particular patient did have associated hearing loss and diabetes as well. And she never mentioned that before to anybody else. But we knew enough to prompt the question and the answer. And to her surprise, we discovered that she had a mitochondrial macular dystrophy instead. And knocking on wood, to this date, putting her on the appropriate supplements, we've been able to contain the progression of the problem quite a bit. And that also impacts favorably the other manifestations of the conditions, including reducing the odds of developing complications from diabetes if one recognizes. Last but by no means least, to the bottom and right, I hope that people can appreciate that the central part of the eye of that particular patient has a very different glow, a very different sheen to it. That's called a tapetum-like sheen, like the tapetum of dogs, for example, that have the kind of glistening reflex from the back of the eye. And then from the very same patient, we see the autofluorescence image that shows a halo corresponding to the glow, but also shows much more clearly the area of suffering in the center. And it turns out that this patient actually has an X-linked type of macular dystrophy, which is related directly to the same gene that causes X-linked retinitis pigmentosa, and that's the RPGR gene. So that was quite surprising to them to learn that, because in this particular case, the patient was not aware of the family history that then subsequently we discovered. So this could also open up important treatment possibilities down the road if the gene therapy with this gene were to be successful and could be extended to patients with these kind of manifestations as well. So let's move on to the next slide, Bailey. So we covered the first part. So I think you all probably know better than me what macular dystrophy does to our vision. And some people, that may have logged in may have been diagnosed recently and not necessarily know what to expect. So I will make assumptions and we'll just try to make clear that even though a macular dystrophy is certainly a very important problem to one's vision, not try to sugarcoat that by any stretch of the imagination, but I always make it a point of telling everybody that a macular dystrophy, so long as it is a true macular dystrophy, does not cause blindness. And when I mean blindness, it means, losing all of your vision. It can definitely lead to legal blindness if the damage in the center progresses to 2200 visual acuity or less. So that's certainly nothing, that is not important by any stretch of the imagination, but it's certainly less severe, less serious than losing, all of one's vision. And for the most part, it makes it tougher to read at distance and at near. Many times, especially in some of the images that I showed earlier, where the lesions don't affect the center right away, but in fact, they are affecting the donut-shaped area, the retina right around the center, then that donut can make it difficult to read, because as one is reading, one may be losing track of what one is reading because it's cutting away some of the areas that one is trying to read. The same when one is trying to look at people and recognize their facial traits. It's a little bit like looking through a mini tunnel, and then there's good vision all around it. Some macular dystrophies will also cause a problem that's called photophobia or light aversion. That means that when lights are bright outside, it can make it very challenging to see. So if anyone has a macular dystrophy, that's likely to happen. Some conditions that affect both the rods and the cones in the retina, which are the two photoreceptor cells, the cells that perceive the light when the light hits the back of our eyes. When both cells are affected, then some patients can also complain of poor night vision. And that's a common complaint among Stargardt's patients, the macular dystrophy that is recessive, and that's the most common one that I alluded to in the beginning. And that's in that particular case, there's a very specific mechanism associated to that. And we'll discuss it in a second because it's therapeutically relevant. The way we diagnose a macular dystrophy is not just by looking at the images that I just showed you. Those point us in the direction of what the problem is. They show us that the damage is concentrated in the macular area for sure, but then we need to add to that. You already heard that Foundation Fighting Blindness offers the opportunity for free genetic testing. That's a very important test, of course, and it's really something that we advocate for everybody. All of my patients, one way or the other, get routed in that direction, and we pursue that aggressively. The reason why that's very important, of course, is that it gives us a diagnosis of certainty. It tells us exactly what the problem is. It tells us which genes involved, which then can open doors to different treatment approaches. It tells us what kind of genetic changes are affecting the patient. And as it mentions in my next point in this slide, there have been very important natural history studies of Stargardt's disease. The Foundation Fighting Blindness is sponsored, they're called ProgStar. And there's many papers that have been published out of ProgStar that have shown very important pieces of information about how the condition behaves and over time and its characteristics and so forth. And these studies have been key in increasing our understanding of the disease and helping companies design better trials to try to treat the disease. And those trials are either already in progress or are forthcoming and very soon. So if we have the genetic information about the patients, we wouldn't be able to study the condition as accurately as we can now. And we've also learned by having this genetic information that some genetic changes are more benign than others, and others instead are a little bit more aggressive. So we can also offer a better prognostic information to patients and make sure that they know what to expect with a greater degree of clarity and certainty. And so genetic testing is really very important. And the type of mutation too can make a difference, not just because of what I just told you, but also because there are forthcoming treatments that will target specific type of mutations. That's what we call them, these genetic changes. There are some of them that are called nonsense, meaning they put a premature period in the genetic material. And so the machine that is reading the genetic information to translate it into a protein gets confused, finds the period, assumes that everything that they need to read is over, and they stop reading the information right at that point. And that causes the protein to be produced, to be severely truncated. And when it's truncated and it's missing a piece, it cannot do its job. The relevance of this is that there are treatments that are being developed that would allow that machinery that gets tripped up by the premature period to read past it and keep reading what's after that. There are entire companies that are focused exclusively on developing treatments like this. And so knowing the type of mutation, not just the gene, could prove very soon fundamentally important in tackling these issues better. One of these drugs has already received EMA approval. The EMA is the European FDA for a condition that is called Duchenne's muscular dystrophy. And so it's hoped that there's going to be more and more of these drugs available, and patients that have those particular type of mutations hopefully could benefit from these drugs as well. But at the same time, we don't just see patients in the clinic on the fly, and then we just say, okay, well, yeah, we see you have a problem in the macula. Let's just run a broad genetic test. That's all we need to do. That doesn't cut it, because that's what we call the genotype, but we need to concentrate also on the clinical disease expression, which we call the phenotype, because if we don't understand that correctly, then we may fail to identify the genetic cause for problems. The example I brought up earlier of the mitochondrial macular dystrophies is the perfect one, because in that case, we do not have the mitochondrial DNA and mitochondrial genes included normally on the panels for retinal dystrophies. And so if we clinicians fail to recognize that that looks like Stargardt, perhaps, but it's not, then a negative test may lead us to the incorrect conclusion that that patient just failed to show what the problem is. Gotta be in some gene that we haven't discovered yet, but just be patient. At some point in time, it's gonna come up. Well, it may be that we're just looking at the wrong pool of genes. And so if we haven't done our homework and making sure that the patient has the correct condition, we cannot run the correct test either. And so it's very important that we do our due diligence as IRD specialists to run all the possible tests that apply in these cases. And that includes doing visual fields, electroretinograms, of which there is different types, and all the other ancillary imaging studies that we can do. And depending on the severity of the vision loss and the type of vision loss, we can change those around and make them more suitable for the individual case of the patient, but they're very, very important. So we appreciate everybody's patience when they come to clinic who wonder why it takes us so long to get through the workup, because we need to run all these tests, and we try to run as many tests as possible on one day so that we make it easier for the patient. They don't have to come back, time and time again to have tests done one at a time. It would be easier for us to do it that way, but we take for granted that patients would rather not have to do the back and forth driving, which, as we know, when you have a macular dystrophy, could be very difficult, which then means that somebody else in your family has to drive you over. And if you're living several hours away from where one of our centers is, then it's many hours of driving back and forth. So we try to cater to what we feel are the patient's needs and try to compact everything into one session, which does make for a longer, testing session, sometimes even over 2 days in a row. But we feel that at the end of the day, it's more informative, more useful, more conducive to success for patients. Natural history studies, as I mentioned, remain very important. So I thank everybody who's participating in ProgStar. That is very important, because without you participating in natural history studies, we cannot get the information that we need to help you better. So we each need each other from this point of view. We understand the natural history study, because they're non-interventional, meaning there's no actual treatment is being offered, be less appealing. They're very, very important. Sitting at home, not participating in these studies, waiting for the treatment to be magically discovered, it's not the right approach, it's not the right strategy. And so we keep encouraging everybody to always participate. And so far, I feel we've had great luck from this point of view, and we appreciate everybody. Now, treatment-wise, for macular dystrophies, we don't have a cure. We all know that. We wouldn't be having this seminar. We wouldn't be needing the involvement of foundation planning and blindness as much if we did. But we're working in that direction, and there's a number of things that we know that can can help sustain the health of the macula better. We know from studies of macular degeneration and also macular dystrophies, for example, that dietary supplements like lutein and zeaxanthin are helpful in delaying the progression of the dry type of macular degeneration. And there's no reason to assume that they are a complete waste of time. Instead, say, for example, in Stargardts and other conditions like that. So we tend to recommend this to everybody. And the reason why they're helpful is because they physically accumulate in the macula. So we don't typically recommend them as much if there's a lot of pre-existing damage in the macular region. But if there is still quite a bit of tissue to protect, especially if the very center of the macula is still intact, and we're trying to make sure that whatever visual acuity the patient has at that stage is maintained for the longest possible time, then it's worth doing. There's a ton of evidence at the scientific level for benefits from lutein and zeaxanthin to macular health. And again, like I said, they physically accumulate in the macula, and they're important to have and maintain at a high level. So those are things that, for example, we already recommend. There have been published studies both at the clinical and preclinical level, meaning in animal models, where in other dietary supplements, saffron, the spice, has been tested. One may wonder why saffron. It's been discovered that saffron contains two neuroprotective agents, that are called crossin and crossetin, that have been identified, purified, and have been proven to be neuroprotective to photoreceptors. So, not most people, at least in the US, don't incorporate saffron in their diet as much. But again, even if you did, it's hard to get enough saffron in your diet just from eating it. So we always tend to recommend supplements from this point of view. And there are a number of them available on the market. Other possible treatments, depending on some types of macular dystrophies, could include also DHA, which is part of the omega-3 fatty acids family. And some of them have been tested in some forms of macular dystrophies. In the patients who have the RPGR gene, the X-linked condition that I mentioned earlier, even though they don't have RP, it's known that when one has changes in the RPGR gene, there is a defect of the DHA metabolism in the body and as well as in the retina. So even though no trial of macular dystrophies linked to RPGR have ever been conducted, it's not unreasonable, for example, to recommend in those particular cases high-dose DHA supplements. Last but by no means least, recently there's been very strong evidence published that shows that a dietary supplement, which is called NAC for short, and acetylcysteine, shows a great deal of promise at protecting the cones of the retina. And the macula is very, very rich in cones. So the very center, in fact, only has cones. So while, again, there's not been a trial that has been conducted yet for macular dystrophies from this point of view with the NAC, there has been one that has been conducted already for RP, retinitis pigmentosa, showing some really substantial promise. And so we look forward to the outcome of the next trial, which has been funded, and we plan to participate in that as well, to see how that helps the health of the cones. But even though RP is RP and macular dystrophies are macular dystrophies, cones are cones. And so if NAC is neuroprotective to cones, there's no reason to expect that it wouldn't be neuroprotective to cones, say in Stargardts or another macular dystrophy. And so in general, since there is no immediate trial on the horizon that I'm aware of to test NAC in macular dystrophies, when patients ask about the supplement, which everybody at this point probably has heard of already, we tend to recommend it as well to them because we don't see definitely a downside in doing it. It is to be understood also that NAC has been used for over half a century for totally something else. In fact, several things. things. It's a detoxicant for liver intoxication from taking too many non-steroidal anti-inflammatory, as well as being used as a mucolytic agent, meaning it loosens up your mucus in your respiratory tract, whether you like it or not, and it works really well at it. So anybody who gets on the NAC supplement, we always tell them, be aware of that. It's not a side effect, that's what it's supposed to do, and it will loosen it up. So if anybody's got bronchitis or things like that and whatnot, they may end up with postnasal drip or increase in their cough, and it's an expected outcome from being on the NAC. Now, last but not least, it's important to understand also that there are things that we can do to overcome the visual burden imposed by macular dystrophy today, especially if one arrives to the clinic and their vision is already 20 to 100 or less. Thanks to doctors like the one that I see is following us all the way from Brazil, Dr. Matsuhara, and who is a low vision specialist dealing with RD patients down in Belo Horizonte. There are many things that we can do to help patients that have macular dystrophies today. Low vision specialists can help somebody who has 20 to 100 or less visual acuity even to get back in a car and drive, because there are telescopic lenses that can be fit, and Bioptic Lenses, that's what they're called, and they can be put on top of the glasses, and there's a couple of different versions of that. The more modern one allows patients to use the lens on both sides, and they'll usually achieve enough magnification to permit safe driving while at the same time not cutting off the peripheral visual field, and so be able to do both things almost as good as before suffering the vision loss. But there's also a number of other devices that are available, and these devices allow facial recognition. For example, when one is looking in the direction of somebody, it will recognize the faces of the people in front of you, or they can help you read what you're trying to buy at a supermarket, or even recognize what kind of money bill you may have in your hand, or what credit card you may have gotten for you. There's even apps that I've heard of through, I believe, Facebook, where you can actually engage directly somebody for you while you're doing all these things and be your buddy through all of it, and they will do the reading of things for you as well that you can take advantage. And then a number of other devices, resources, and setups that can be used as apps or to improve your cell phone function, your ability to read, on a computer screen, and so forth. There's many different ways, and low vision specialists can really help a lot with all these things. One other thing that I would like to mention when it comes to the treatment options and also the future outlook of that are the following. Stargardts, I mentioned earlier, we've learned a lot about Stargardts from ProgStar and other studies as well. One of the key things that, somewhat surprisingly to me, most patients with Stargardts walk into my clinic without having heard a thing about it, is that the gene that is involved in Stargardts, true Stargardts, the recessive type, the ABCA4 gene, what it does in the retina is to help the cones and the rods of the retina recycle vitamin A. Vitamin A is needed for our vision. Without vitamin A in the retina, we can't see. So it's a damn if you do, damn if you don't kind of situation. But with Stargardts, when the protein, the enzyme that should flip out the used up vitamin A out of the photoreceptor cells to send it to the cheese layer, the RPE, underneath the retina for recycling, and then be made back available to the retina, then what happens is that the vitamin A that is being used up once the light hits the retina gets stuck in the tips of the photoreceptor cells, and it doesn't get into the cheese layer until the cheese layer is done chewing off those tips, which is what it does every day. It's doing it at the back of the eyes of all of us as we speak. It's chewing away a little bit of those tips every moment. So when that used up vitamin A gets plopped into the cheese layer underneath it, then it intoxicates it, because when it's used up like that, it is what is called oxidized. It turns oxidized into a substance that's called A2E. A2E is toxic to the RPE, the cheese layer. And when there's a big load dumped on it during the process in Stargardt, it unfortunately cannot be eliminated fast enough. And then it ends up causing more and more damage of the RPE, which then in turn makes the health of the photoreceptor cells on top even worse and creates the proverbial vicious cycle. And so at the end of the day, we cannot go completely vitamin A free, because we need some vitamin A in the system. If we were to be 100% vitamin A free, we would ultimately become blind. But at the same time, we don't want to supplement ourselves with anything that contains vitamin A, because if we keep feeding this process and we pile up more and more vitamin A in the system, then the expectation is that it's going to lead to more and more of those lesions at the back of the eye that cause the cheese layer to turn into Swiss. And it is so true that most trials that are ongoing or they're about to happen are all focused on drugs that either impede the further recycling of the vitamin A back into the retina, or the delivery of the vitamin A to the retina altogether. So as an avoidance recommendation that we give to anybody who has Stargardt, we tell them to make sure to avoid the foods also that are too rich in vitamin A, and we provide them with a list, and as well as making sure that they do not take a multivitamin. Most people assume a multivitamin is going to be good for you, and it is normally, but a typical multivitamin contains really high levels of substance that people don't know is the same as vitamin A, and beta carotene. Beta carotene it's basically two molecules of vitamin A attached to one another that then our body breaks down into molecules of vitamin A. And so vast majority of people who walk in there in a clinic will be or have been at some point in time on beta carotene, or don't know, for example, that even though everybody thinks that carrots are good for your eyes, well, and if you eat a lot of those and you have Stargardt, you're probably not helping yourself, because you're putting more and more vitamin A into the system, and that can actually feed forward the disease and not help it. So this is, I think, a very important piece of information that we give really on a routine basis to anybody that tests positive for ABCA4 changes, whether this applies to other macular dystrophies where those bright deposits that don't turn into dark areas at the back of the eye or not. We don't know. We honestly don't know if another dystrophy is the same mechanism could be at play, but it certainly wouldn't hurt you to avoid or minimize the intake of vitamin A and beta carotene also in your diet or through other supplements, even if you have another macular dystrophy. In fact, even in the AREDS2 trial for macular degeneration, for the age-related macular degeneration, the newer supplement that we tested at the time was beta carotene free, and it worked just as much as the previous one that had the beta carotene in it. So that's an important piece of information. I find surprisingly most patients with Stargardt have never been told about, and we find that it could be very important in minimizing any additional contribution, unintentional contribution to the progression of the disease. And then in addition to that, I just want to spend a quick word on what's coming. Everybody has heard of stem cells, and everybody wants to always ask a question about stem cells. I'll be happy to answer additional ones if you may have them. But right at this moment, the most promising approach perhaps to restore some central vision, people who have lost a lot of it, is actually optogenetics that delivers a gene with a light sensing pigment to the surface of the retina, so that patients could regain some central vision. Some of that is in undergoing testing as we speak. There's more of that coming down the pipeline quick, and we hope to see some positive outcomes from these trials and also the future trials, and that can this improve vision further, and in patients that have already lost it. So I will stop here as I've talked plenty, and I would like to leave a few minutes, for some questions from anybody that may have any. So thank you for your attention.
Great. If anyone has any questions, feel free to hop off mute and ask away, or feel free to hit post them in the chat feature at the bottom of your screen, and we can go through them that way as well.
Don't be scared. That's your chance to ask the question.
Tom, does anyone in your crew have any questions? I know you have a few folks that are all grouped watching together.
I don't know. Do y'all have any questions?
No.
No. I guess one general question I might have is, of course, I see Dr. I up at the Duke Eye Center in Durham, but there's also an office here in Winston-Salem. Will they perform the same type of test on the initial visit that I did in Durham?
Short answer is no. That's why I see patients only at one location, because to have all the bells and whistles that you need, we just had to have them at just one place. Now they do have an OCT available, and I'm not sure what other one of the imaging devices they would have, but all the other bells and whistles with the functional testing and whatnot, unfortunately, they're very expensive pieces of instrumentation, and they're just not suited for relatively small satellite clinics or things like that. It just needs more than that. So it can still give some useful information. So yes. Yes, Barbara.
Oh, good. I've been trying to find a low vision specialist that would write a prescription for me. And I contacted this company in Greensboro, Hecker Eye Associates, and they said that they can do that, but they want you to send them all my records before they perform the exam for me.
Okay.
So who do if I call Duke tomorrow morning, what department do I ask for?
Medical records.
Medical records. Okay. And you'll give permission for them to be.
I've got nothing to do with you. You give the permission. I don't give anything.
Oh, okay. Okay.
Those are your records, not mine. So I can give permission to release my records, but not yours.
I don't want your records. So
I didn't think so either.
They won't
Right.
help me.
Right. I didn't think so either. Yeah. So no, those are your records. That's your information. So long as you give them the permission to do it, they can definitely release them. I have no knowledge of what the timing of the process would be or what the process really entails, but that's what you need to do.
Thank you. I'm really anxious.
Yeah, absolutely. Yeah,
Yeah.
no problem. No problem at all. Now, yeah. Remember, obviously, that we do have a very strong low vision and an occupational therapy team at the Duke Eye Center as well. So if you need further assistance with any particular type of devices, there's pretty much nothing that they don't have. And they have plenty of personnel that can see you. Again, they have two occupational therapists on staff that will help you a lot with fitting you with all sorts of things and showing you all the different devices that are available. And I thought I heard Laura who wanted to weigh in.
Yeah, I was just going to echo on what you were just saying about Duke's low vision opportunity as well as an option. I wasn't sure if you knew about that, Georgia.
Yeah.
I'd like to.
So, yeah. Go ahead.
I'd like to go back to the importance of genetic testing, which is a key to all of this. And if a patient came to see you for the first time and you did the battery, the all-day test, and you know, and I think that we can appreciate now why we have to do these tests. Could you, at the initial consultation, work with them on getting the genetic testing through the foundation?
Well, we work at getting the genetic testing done, period, whether it is through the foundation or not, absolutely. And we typically do it on the very first visit. There would have to be some physical impediment to prevent that. Like, for example, I don't know, the nurse that works at the lab to collect the samples is, you know, out sick or something like that, you know, or some other situation where our visit at the end of the day ends up after 5 p.m. and that's usually when the laboratory closes, you know, things like that could get in the way. But at this point, you know, that too has become a non-issue because there are kits that are available you know, all the data requires, like in the movies, to do a cheek swab, and you can do it also from the comfort of your home. In fact, we do that a lot, even for patients that live far away, or they may need to leave early and they cannot wait. We send them the kit later. Laboratories can send them the kits directly. We don't need to get directly involved with that. The one thing I want to emphasize is, since you brought the issue of genetic testing back up, is the importance of testing not just the patient who is affected, but if they are the parents. Okay, so because without information about what we call the phase of the mutations, as we call them, right, these genetic changes we're looking for, knowing who passed on what, okay, it's very hard sometimes to draw firm conclusions about what's causing the problem in any given patient. It's very common that patients come back positive for a number of changes, and if you haven't looked at the parents, then you cannot really sort out what was coming from home. And then you may draw, frankly, totally incorrect conclusions. Even the laboratories sometimes draw incorrect conclusions. They put a lot of emphasis on some changes that they think may be important for the patient. But when you actually look at what the patient tested positive for, because we've done such a meticulous job at characterizing the clinical expression of the patient, the phenotype I alluded to earlier, then we can say, yes, I see that it could be disease causing, but in the case of this patient, it's this other gene that fits like a glove and explains very precisely what the patient has. So we overrule what the laboratory is saying. If you haven't done that job, ahead of time, your homework there, then you can draw wrong conclusions. In fact, we see a number of patients that are referred to us who already have had genetic testing even before they come, but the parents weren't tested, the doctors weren't qualified to actually interpret the results correctly, and they jump to conclusions and they send us the patients as saying this patient has RP, or this patient has Stargardt's, or whatever they think they may have. And then we look at the patients and we say, wait a minute, where do you see that? The laboratory report said something, but you really didn't read it right and didn't read it into a proper context. And so at the end of the day, the patient may have totally something else. So genetic testing, key, very important. I cannot overemphasize it. So thank you for bringing that back up. Whether it's done through the Foundation Fighting Blindness or not, it remains fundamental. I've always been a strong advocate for insurances to have to pick it up, because this is something they really should be paying for. These are diagnostic tests. This is not research. And I know that there's a number of companies that are trying to put more and more pressure on them from this point of view to make them understand that. In fact, in 2 weeks, not even 10 days from now, I'm going to be participating in an educational seminar where the people I'm going to be talking to are primarily health insurance providers that want to understand why all of this is important, and why they should be actually covering for it. We also establish precedents, even if Medicare denies coverage, there's ways to appeal that. We always encourage that. We have a legal precedent where we actually won the case going all the way up to the administrative law judge and advocating on behalf of one of our patients. So they saved $14,000 worth of testing that they've been charged with. So we're very happy with that. One thing that I wanted to make sure that everybody understands is the connection between, and thank you, Ben, for bringing the comment up, is what is the difference between Chondral dystrophy and Stargardt's disease? Chondral dystrophy and Stargardt's disease, at least to a certain degree, are like brother and sister, or if you wish, first degree cousins. The same gene, the ABCA4 gene, can cause one and the other. So it's not uncommon that we have patients that come to clinic, they've been told they have Stargardt, which has one implication, one prognosis. But in reality, when we test them, when we look at them more carefully, we say, well, yes, something that looks like it perhaps, but you have more than that. Or in fact, something that may have looked like Stargardt, and it was true, maybe 20, 30 years prior, but now it has evolved in more. And so a chondral dystrophy is basically Stargardt's plus disease, if you wish, that has continued to grow from the very center area and creates a much larger area of vision loss. And that's where we feel that making sure that one tries as hard as possible with some of these potential or delaying type remedies that I alluded to earlier becomes important, because if you now project the condition 20, 30 years down the road, that can evolve. And I've seen patients, because I've been seeing patients that long, that actually can evolve from the Stargardt stage to a chondral dystrophy frank stage. So today, in fact, we saw a child who was, it was 11 years old, and he was told he has got Stargardt, and that's true. But the type of mutations that he has, we already know what those are, and the kind of presentation he has predict that over time he will develop a chondral dystrophy. And so the parents were completely unprepared to that, because they said, well, we were told that Stargardt, once visual acuity is lost, has reached a certain level, that's it, and nothing else is going to happen. It stops right there. And I was going like, yes, that's what I was told too when I was a resident. But that's just about 30 years ago. So Ben,
Right.
yes, please.
A quick follow-up. Are the RPE cells affected in cone rod the way they are in Stargardt? You have the accumulation of lipofuscin.
Right. So that's a great question, right? The only way that we can answer that is by retrospectively, I guess, or prospectively, looking at the patients that evolve from a more typical Stargardt's phenotype all the way into the chondral dystrophy, right? So we do see that there are patients that are affected that way. We do. So we presume that in those cases, those same mechanisms that we're trying to interfere with today would be ameliorated by the various treatments, including the trials that right now are focused on Stargardt's, should in theory prevent or at least minimize the odds of progressing from Stargardt's to chondral dystrophy. On the other hand, there are some patients, and maybe that's true more for the ones that have a more aggressive type mutation, whether it's the ABCA4 gene or not, in which there is more immediately obvious damage to the RPE layer. So basically, there's already a large hole in the cheese layer right in the middle, and what could have triggered that? Unfortunately, by the time you see the patient at that stage, it's hard to know if in years prior there were those same deposits or not. It's possible that there are other mechanisms. In fact, some trials for Stargardt's are focused also on inflammatory aspects of the disease as well, to try to tackle those. So maybe those patients had a stronger inflammatory component that never really allowed for the other process to come to full fruition and other events happen. So that's a very good point. But we hope that by and large, the mechanism that is at play is, if not exactly the same, it's at least similar enough that the treatments that are being tested for proper Stargardt right now could be helpful for some of the chondral dystrophy patients too.
Great. That's
Now,
very helpful.
yeah. Yeah, absolutely. So I see that there is a question here about some testing. Okay. Yeah. So fair enough. So the problem with when so first of all, you don't submit DNA tests to the Duque Center because we don't run the tests. So if you sent your DNA to the Duque Center and you didn't receive results, that's why, because we are not the ones who run the test. So any DNA sample needs to be sent to the laboratory that runs a test. Anything that gets sent to the wrong place, unfortunately, ends up to the wrong place with no answer. And unfortunately, we don't really get notified of what happens with, a sample that is received in error. So nothing trickles down to us, I'm afraid, from the point of view. Now, if the test has been, the sample has been sent to the laboratory that actually ran the test, say on defective child in this case, then it's usually the responsibility of the laboratory to notify us of the results, if nothing else, because we cannot know when people from their homes send samples, to laboratories. So when they notify us that there are results available, and they make them available to us, then we can review them and go from there. So, and I see what you're saying. The test was done at Duke Eye Center, but I can assure you it is not. So unless it was like 30 years ago, and then I have no idea how that was done because I've been at Duke Eye Center only since 2016. So, but we do not run any diagnostic genetic test at the Duke Eye Center, period. No, that's for sure. So this is something that we can try to maybe resolve by you contacting maybe my staff and then try to dig into that, because I don't have an answer for you right this second, but I can assure you what I just told you, that's for sure. So, any other thoughts, comments, ideas? Ben, did I miss something? Did I forget to mention something that was important? Besides what you already brought up?
Not that I can think of. No, you were pretty thorough. Thank you.
Thank you. Yeah.
Great. This was wonderful. Does anyone else have any last minute questions?
I just want to say on behalf of the Triad Chapter, we really thank you for taking time out of an extremely busy schedule to spend this hour with us.
Thank you.
So greatly appreciated. And we thank the foundation staff for all the work that they do for us. So thank you so very much.
Thank you. Thank you for saying that. Absolutely. And yes, we cannot say enough about, what the foundation does to permit all of this. It's been a long, lifelong mission, for me, at least when it comes to my professional life. So I look forward to continuing to work with Ben and now Bailey as well. I hadn't met you yet, but it's a pleasure. Ben, I've known you now for a while. So look forward to continue working with you. So.
Same here. Thanks, Alex.
Yes, we're
You
so
bet.
happy and blessed that you're at Duke. And when I heard you were coming there in 2016, it just made me really giddy, and I'm still giddy. And I'm so thankful that you have so much passion and drive into finding, what's causing all these RODs. And just thank you, thank you, thank you.
Thank you, Laura.
Yes.
Appreciate you.
Thank you.
Thank you, Robert.
Great. Well,
All
we
right,
will
then.
go ahead and get wrapped up then, and we'll close ourselves out here. So once again, thank you so much, Dr. I, for this presentation. I think that all of us got a great deal out of it. If you have any other follow-up questions that you may have thought of once we've all logged off, feel free to send them to our email address at chapters@fightingblindness.org, and we'll make sure to get those directed in the right place. And then lastly, I just wanted to say a quick thank you to our sponsors who help make events like this possible and are able to get us all grouped together. But have a great rest of your evening, and we look forward for you to join us at our next speaker series.
Thank you again for the invitation. It was a
Thank you
great
all.
privilege.
Thank you.
Have a great
Goodbye.
evening.
Take care, guys.
Have a good evening.
Thank you.
Bye-bye.
You too. Thank you.